In the emergency room, the acute abdomen is one of the most common presentations for a surgeon. It follows a highly predictable clinical course: colicky pain that begins vaguely around the umbilicus before localizing into a sharp ache in the right iliac fossa. Looking at the clinical course, we see the pain is usually accompanied by 5 secondary features: nausea and vomiting, a mild pyrexia, abdominal tenderness, and an increased pulse rate. The 6th point on this list, neutrophilic leukocytosis, marks the presence of a systemic response. A blood test reveals a massive spike in white blood cells, indicating an active inflammatory process is already underway. This constellation of symptoms, from the fever to the white blood cell count, is the direct outward manifestation of an escalating ischemic and inflammatory cascade occurring at the cellular level. Understanding that cascade requires a look at the appendix in its healthy state. It is a vestigial diverticulum of the cecum, essentially a blind-ended pouch averaging 7 centimeters in length. While it serves no useful purpose in humans, it possesses a complex 4-layer wall structure shared with the rest of the alimentary tract: the mucosa, submucosa, muscularis, and the outer serosa. This H&E micrograph shows the uniform arrangement of these layers. The inner mucosa contains patchy crypts, while the submucosa directly beneath it is packed with abundant lymphoid tissue. This intact architecture is the organ's primary defense. The clinical severity of appendicitis is determined by how deeply an infection manages to penetrate through these specific structured layers. The path to organ failure begins with a mechanical event, the obstruction of the appendiceal lumen. The causes for this blockage are diverse. A fecalith, a hardened mass of feces, is the most common, but the lumen can also be obstructed by gallstones, foreign bodies, tumors, or parasitic worms. While non-obstructive causes like vascular occlusion exist, they're less common. Regardless of the trigger, the result is a rapid disruption of the organ's internal environment. Because the appendix is a closed tube, any blockage causes mucus to accumulate. With nowhere to drain, the intraluminal pressure spikes, pressing outward against the mucosal walls with increasing force. When internal pressure crosses a critical threshold, the mechanical stress begins to compromise the biological integrity of the appendiceal wall. This rising pressure creates a mechanical vice, compressing the network of blood vessels within the wall. The intense compression collapses the venous outflow first, effectively starving the delicate tissue of oxygen and rapidly inducing acute ischemic injury. As oxygen levels drop, the cells of the protective mucosal barrier begin to die, losing their ability to shield the deeper layers of the organ. This creates an opportunistic environment for bacteria. With the mucosal barrier compromised and the environment oxygen-starved, bacterial colonies proliferate rapidly. The ischemia and bacterial invasion create a self-amplifying loop of destruction, where the organ's own internal environment begins to digest the wall from the inside out. For a pathologist, the absolute diagnostic criterion for acute appendicitis is the presence of neutrophilic infiltration within the musculatus layer. This histological diagram shows the evidence of failure. The inner layer is necrotic mucosa. Beneath it, congested vessels draw massive influxes of inflammatory cells, labeled as neutrophilic infiltration. On the adjacent H&E slide, these appear as dense microabscesses buried deep within the muscle. The presence of neutrophils in the muscularis is the definitive proof that the mucosal barrier has failed, and the structural integrity of the organ is severely compromised. This microscopic breakdown transforms the physical appearance of the organ. In early acute appendicitis, the appendix appears swollen and hyperemic, red with engorged blood. As it progresses to acute suppurative appendicitis, the outer serosa becomes coated with a thick fibrinopurulent exudate and heavily engorged vessels. This diagram reveals the underlying cause. An impacted concretion, or fecalith, has created the obstruction that drives the inflammatory exudate to the outer surface. If the pressure is not relieved, the tissue enters acute gangrenous appendicitis. The wall becomes greenish-black with necrosis and grows dangerously soft and friable. This explains the patient's migrating pain. As inflammation reaches the outer serosa and irritates the parietal peritoneum, the vague umbilical ache localizes into sharp agony in the right iliac fossa. When the friable wall finally gives way, the appendix perforates, spilling infected contents directly into the sterile abdominal cavity. perforation leads to severe local complications, including generalized peritonitis and the formation of a localized appendix abscess in the right iliac fossa. Without intervention, the infection can spread systemically, creating fibrous adhesions to surrounding organs, or triggering portal pilophlebitis, septic inflammation that spreads to the liver via the mesenteric veins. Ultimately, the acute abdomen is a mechanical failure that triggers a predictable ischemic cascade, ending in the total necrotic destruction of the organ.